Hi everyone, welcome to Ask the Dentist. This is the first video of many, I hope. And you know, we could have started with interviewing many people, but I thought we would start with something that is very close to my heart, and I'll tell you why later in the video. I thought we would start with speaking to a myofunctional therapist, and you know, what the heck is that? And that's going to be the point of this little broadcast, this little video. I really am so glad that Sarah's here. I've known Sarah Hornsby. I've known her for, I think it's been 5 or 6 years. She helped us write a appendix in our book on sleep, which turned out to be a bestseller on sleep, surprisingly to us. And now in hindsight, I'm thinking back, I mean, that appendix was very, very important. When my daughter and I wrote this book, we were doing a lot of research, and we realized that we were weak in the myofunctional aspect of this. And of course, we're gonna dive deep into this and explain why that's so important to sleep and to overall health, also oral health. But you know, Sarah came to the rescue and helped us with that. And she's here again. So I'm very excited to introduce Sarah to you. We're going to kind of talk about why it's so important for dentists and patients, so there are a lot of dentists watching this as well, to know about myofunctional therapy. So without any further ado, Sarah, thanks for coming. It's great to see you again. And thank you for writing our appendix in our book. We've collaborated for so many years, and I look forward to so much more. So
Yeah.
I want to go right into it. I don't want to waste any time.
Thank you. You've done so much in this field for bringing awareness to myofunctional therapy, and I love that you've chosen me to do your first interview like this, because I think it's such a great idea. So I didn't even realize I was the first person, but
well,
awesome.
I mean, again, as I said, we spoke earlier. I mean, I want to start way upstream. I'm a functionally minded dentist. I think that's the only way one should practice as a dentist, as well as a physician. We got to start upstream and start with, we got to be treating people, you know, in the prodromal phases, pre-prodromal, that's not even a word. I mean, we need to go to the root cause right away. If we don't know what the root cause is, that's fine. We should always think that there is a root cause and that, you know, it's time to address it. And that's what your profession does. And I mean, you know, as far as I'm concerned, you're one of the leaders in that area. And we were talking about that earlier. We're waiting, you know, you're going to write a book. You're now working with the Breathe Institute at UCLA. I mean, you've really been very passionate about it. Before I ask the big questions, how did you get into this? I mean, sometimes people have a healthcare issue that leads them to their passion, their profession, or sometimes it's vice versa. They just pick it and then later realize that they've got some health issues that are related to that. What's your story?
You know, I started off in 2010. I just needed some CE credit. I was a hygienist and I was looking for something I could do. And in the back of my mind, I had been practicing hygiene for about 2 years, and I was looking for some other career path ideas as well. So when this opportunity popped up, I thought, oh, I'll get the training, and it sounds interesting, and I've never heard of this field. It's really kind of weird sounding, but why not? I'll go for it. And so I was actually sitting there in the class getting training, realizing that I had a lot of the symptoms myself. And when we can talk more about what those are, but basically low tongue posture, open mouth posture, mouth breathing. And you know, it's also one of these things that I think a lot of people are embarrassed to admit to or talk about. Right. And I was horrified, I have to say, like when I was in the classroom as a hygienist learning these things and learning that they connected to me, I was probably in I would say denial to some degree, because I thought, I'm a hygienist, I should know about these things. If this was real, I would know. But the other part of me just bugged me that I knew I had the symptoms too. So I think if it wasn't for that, I wouldn't have pursued the therapy so much and gone down that path. But I had the personal connection, and I'm just a curious person. I thought, why is no one talking about this? So that's kind of where I ended up today, and that was 10 years ago. So
So yeah, I want to talk about oral posture. I'm fascinated by it, but I was in the same boat, probably even less aware. I think hygienists are actually ahead of the curve. I went to dental school, which really put these big blinders on me and handicapped me. And I had no idea about it. We spoke about one thing. I remember, this is again 34 years ago. We spoke about tongue thrust, and that was it.
Mm,
And because, and this was in the orthodontic kind of chapter of my you know dental education, it was because it wasn't like, what's that about? What can we do about it? It was tongue thrust. You're going to see it because the teeth get splayed out, and if you put braces on that patient, they're not going to be able to hold properly. And that was it. That was
yeah.
my introduction to myofunctional therapy.
And I bet the solution was a tongue crib.
Exactly, right. And so now, after getting a real education, being a practicing dentist, I now realize how important this is and how it really should be. I mean, there should be a lot of units spent on myofunctional therapy, but
Oh my gosh.
that's what you're doing. You're teaching dentists, you're teaching hygienists, you are connecting the two, which is very admirable.
Yeah.
I would say, simply put, that a dentist cannot practice fully to the standard of care without having on site or having access to as a referral to a myofunctional therapist. So why is that?
No,
Let's start.
I agree. That's a really big statement to make too. And I hope all the dentists can hear that, because it's such a root cause for the things that we see every day.
Yep.
Perio issues, rampant decay issues. Of course, yes, the sleep, the TMD.
Right.
But I don't think people realize like how integral it is to dentistry and how root cause it is. So I'm
Right.
glad you mentioned that, because it's a really big deal.
It is, and we talked about this earlier. What I do now, I mean, we get about over 100,000 questions a month at AskTheDentist.com. And of course, we don't answer them all, but we pick out the ones that are either really in need of an answer, or have an educational bent to it, and we can use it to teach others and inform others. And you know, I hear all these stories and questions. And now, instead of saying, for example, we're going to talk a lot about sleep and breathing and airway and how that's related to facial structure and your dental history and development. But so a lot of people I know, just based on what they say, and this is just a little IG question, Instagram question, or it can be you know, submitted to the website directly. It'll be something like, I have crowded teeth, I'm not sleeping well, I'm tossing and turning, I'm tired. You know, my husband or my partner says I snore. So I could tell them to go get a sleep study, but now it's so much easier just to reach out to them and say, listen, see a myofunctional therapist, because the sleep study is thousands of dollars. It's a long process. That's why we wrote the book, to try and simplify that. But now it's just so simple to see a myofunctional therapist on a Zoom call, which you do often, I think almost 100%. And we'll talk about how that works, because I think a lot of people are skeptical, and it does work. I know it works.
Yeah.
And just do a 30-minute, 1-hour Zoom call. And if you have what I call comorbidities of, one of them is poor facial development, mouth breathing, lip posture, oral posture, tongue tie. If you have that, then okay, then we know you've got to go down that longer, more complicated route. But at least it's an easy kind of way to get into knowing whether you need help or not. So what is myofunctional therapy? Tell me what is it in a nutshell, and why is it so important? We've been kind of
Yeah,
starting.
it's really simple. And I think in our field, we can try to make it complex and complicated, and it's really not. So I always tell every patient, and I have a YouTube video that talks about this too. I have 4 basic goals for every person I see. You have to breathe through your nose, your lips have to rest together, touching, your tongue has to be in your palate, and you have to swallow without that tongue thrust you're talking about. So it sounds like, well, why would that matter? Who cares? You know,
Right.
all of these things are so, like, no one else talks about it. So why is it so important? And my message around that is, this is how we should all be functioning. This is normal. It's normal and healthy and natural, and it should be innate to breathe through your nose and have your tongue in your palate. So if you're not doing those things, if you don't have that down and you're a kid or an adult, you have dysfunction. And all I'm trying to do is restore you to normal, healthy function. And that's it. And so when you have the bigger symptoms like the sleep apnea, we still have to restore that normal root cause functional issue that you have with your breathing and your tongue. And then that will only help the other treatments down the road. So it's super important, but it's also very simple. And I don't think we should make it sound so complicated. You know, it's I would say it's a lot like physical therapy. So I teach people exercises, and that sounds really funny and weird, but it's all more than exercises. It's retraining the brain and neuromuscular reeducation on the mouth and face and breathing. A lot of people who haven't been breathing through their nose, their brain doesn't connect that they have a nose and they have to learn to use it.
Right.
So
That's a great
again,
analogy. I like the physical therapy analogy. Most people are resistant, to go. They think they can just sit home and heal after maybe a surgery or an injury.
yep.
But most people, I would say almost everyone that I know of that has done physical therapy, myself included, that was money and time well spent. And it's the same with myofunctional therapy. So I've referred a lot of patients to you and to other myofunctional therapists in the area. And I have to say, all of them, now it may be a child and the mom will come back and relay this information to me, or an adult, and they all come back and I always ask them. And of course, I'm in touch with the therapist, and it's like, well, how did that go? And what, do we need to do more? And the result is always the same. There's an improvement in, the patient's affect. If there's a dental issue or breathing issue, that's improved. And overall, the patient always comes back and says, that is something you need to talk more about. This was very, very helpful. So why are dentists in the dark on this? And I know it's improving, but back in my day, even 5-10 years ago, the whole profession was pretty much in the dark. Why is that, and what can be done about that?
Well, I have a couple theories because I didn't learn about this in dental hygiene school either. What I have learned is that that's not just dental hygiene school, it's also dental schools, but it's more than that. It's speech pathology schools, it's ENT schools. So all of us medical and dental professionals, none of us have this education. So it's really falling between the cracks. I think because it overlaps with so many fields. So it's not just a dental issue, it's a posture issue. It can be a speech issue. It can be an ENT issue. So I think when there's so many groups involved, it's easy to get lost. The other thing is we haven't had research until very recently. I kind of joke that the 2010s are the golden era of myofunctional therapy because that's when we really started to get research connecting the dots between myofunctional exercises and sleep disordered breathing. And it wasn't until Dr. Christian Guilleminault, based out of Stanford, whose predecessor has really been Dr. Soroush Zaghi, that they're putting out information and making it more accessible to the dental population and to the public. So, and they're not the only ones. Dr. Audrey Yoon has contributed a lot. There are lots of people behind the scenes who very recently have been putting out great research. And honestly, that's only been since about 2015 that we had like some really landmark studies done. And so it's easy to see why we wouldn't know about this because it hasn't been in the literature, which means it can't be taught in universities. So that's my theory. And I think now that we have the internet and there's so much access to information, I think the patients are what's driving it as well. So I know, and patients reach out asking a lot of questions on this. I don't think the doctors realize how in demand this breathing and sleep and myofunctional stuff really is. I mean, you get the emails, I get the emails. The dentists, I think, maybe are a little more skeptical, but that is changing. And now that we have the research, I think it's coming from two directions. The patients are going to create change and the research is creating change.
Right.
So.
Yeah, unfortunately, you have the same handicap that a dental student does because typically the hygiene education and dental education sometimes the dental school owns the hygiene school. I see that a lot here in California, but also a lot of dentists teach at the hygiene school. So it's the same handicap, and so don't feel bad. But it's wonderful to discover all this, to work with it, to see the results. So let's talk about oral posture. That's a term that I've only been using maybe for about 2-3 years. And in dental school, I was told that there was this kind of rest position where the teeth are about 5-6 millimeters apart. Nothing was really said about the tongue. We talked about classification of the jaw. How does the lower jaw fit with the upper jaw? We didn't talk much about the width of the jaw and what creates. I mean, I had a facial development textbook. And I looked through that the other day before I threw it away because it's outdated. And I marveled at how little information there was about how the muscles of the face, the tongue, and the tongue is essentially what, 8 muscles. There's buccinator, there's the
Yeah.
swallow reflex, lip posture. There's so much to all of that. It's important with breastfeeding, and then later, that oral posture, where that tongue is, how we swallow. I look at it as kind of like a squeezing kind of tidal wave. That tongue, when you swallow, it starts in
Yeah.
the front and it compresses and shoots the food into the back of the mouth so that it can digest properly. It's like one of those wave machines, right?
Yeah, yeah.
So, but the shape of the tongue, if it's tied down, I definitely want to talk about tongue tie, especially posterior tongue ties. So that posture and what we do with our mouth, swallowing, talking, smiling, getting mom's breast milk. I mean, all of that is so important. All of that to me is so important because it determines the shape of our face. If we don't do it correctly from day one, we've got issues. What kind of issues? We have issues for the rest of our life, from maybe as a child having ADD, ADHD, to not being able to breathe properly, constricted airway, collapsing airway, sleep apnea, and everything that comes along with that, including depression and diabetes and heart disease. And I mean, it's a big root cause. So what is, talk about oral posture, and not from my days, but now it's teeth together lightly, lips closed, breathing through your nose, and that tongue. I always thought the tongue had to lie flat. That's what we were told. It really has to fill that whole space. I think it is like a big sausage or a big Zeppelin or a dirigible, and it's got to apply a little pressure to keep, as we're developing, which ends, it depends on who you talk to. Age 4, most of it is done, 60% is done by age 4, and then up until age 10, some of it still occurs, but that tongue is exerting forces that help shape our face, hence shape our airway.
Yeah, exactly. And so the correct posture should be, and everyone can kind of visualize this, the tip of your tongue should be on what we know as the incisive papilla area, the rugae, and that is the gums kind of behind the upper front teeth. So the tip of your tongue shouldn't be on your teeth or against your teeth. It should be on the gums right behind your teeth.
Right.
And then from there, the whole tongue needs to almost form a blanket across the top of the mouth. So the entire tongue should fill the entire palate. And you shouldn't feel, if this is the top of your mouth, you shouldn't feel a gap of air between the top of your tongue and the top of your mouth. Your tongue should fill up the entire oral cavity. Now, where this becomes complicated and physically impossible is if you do have a tongue restriction or a tongue tie. If you physically can't get your tongue to your palate, now what? What's going to happen to your function? So this is where the tongue tie discussion is really entering into the myofunctional and sleep world, because if I'm trying to restore normal function, but the tongue is limited for so many reasons, we could go into that. It's a whole different topic.
Right.
Now what do we do? And so I look at tongue tie release, and I think this is so important, and I teach this in my classes too. A tongue tie release is a means to an end. So it's a step along the process of normal function. It's not the end goal. It's not the point. So when people just go have tongue tie surgery and they release it, they're not actually getting to that proper function. And so for my goal of tongue and the palate, you might need to release the frenum to get the tongue to go up, but you have to teach the tongue how to actually do that when your whole life you've spent not able to function normally. So getting the tongue prepared before the surgery and then doing post-op exercises is critical and should not be overlooked. So and the
I agree.
lips should rest together.
Yeah, that's really important. I agree with you. And I have the same issue with, so I refer a lot of people to ENTs to have, nasal septal surgery or turbinate surgery or deviate septum surgery. And I think a lot of them think, I'll just have the surgery done, I'll be able to breathe through my nose and everything will improve. And what I always tell them is you should first see the myofunctional therapist to relearn everything, because you've been breathing through your mouth. You don't know how to breathe through your nose, even though it's all of a sudden open. So I would actually prefer to have all that information in the patient's head before the nose opens. So when they can breathe through their nose, they know what to do. Breathing is not necessarily, it's like sleep. It's innate, right? But it's not guaranteed that we're going to do it correctly. So that's where the myofunctional therapy comes into play.
There really is a big disconnect. Like when you haven't used your nose, like I said earlier, people literally, like their brain doesn't even connect. And actually I have a really cool product I'll have to give a plug to. I have no relationship with them necessarily, but I use this a lot. It's called a boom boom stick.
Right.
Have you heard of it?
No, looks good.
So it's like you breathe. I really like it because it's like a menthol. It helps the brain connect like, oh wow, I have a nose. So
Right.
it's such a simple tool to use. It was even on Shark Tank actually. So it's a
Really?
cool product.
So I
But it's
use,
all about, for me, creating awareness and getting that cold sensation in the nose. So now the brain can connect.
right.
So it's a cold menthol sensation, and just getting people to do that before and after a nasal surgery would be better than nothing. Obviously, they're probably gonna need more than that, but such a simple thing that I think we should all be talking to our patients about is just how do you use your nose? Can you
Right.
breathe through it? And how can we start you
We
doing
do
that?
need to connect to nose breathing more. We need to really
Yeah.
be aware of it, think about it. I mean, all the Eastern gurus have been doing that for
Yeah.
centuries. But that stick is very interesting. I'd like to hear more about that later. But I use a little essential oil little roll-on
Same
container.
idea.
It's like underarm deodorant, but it's small. It's got some lavender in it, and I just roll it
Yeah.
underneath my nose sometimes, and it's so wonderful just to be able to smell. You get that little bit
Yeah.
of a kind of a menthol effect, as you mentioned, and it really kind of helps open up the airway a little bit. Let's
Yeah.
talk
That's
about
the same idea with that.
yeah. So let's talk about mouth taping because I'm big on that, and I know it's
Yeah.
not the end all. It doesn't fix a lot of things. It's a Band-Aid, but I use it mostly for as a differential diagnosis. It tells me a lot about what the patient can and cannot do. But we're talking about nasal breathing. So what is your take on mouth taping? I mean, ENTs would tell you not to do it because it's dangerous. A lot of dentists now are on the bandwagon. They see it for what it is. What is the myofunctional
Yeah.
take to mouth taping?
I love mouth taping. I recommend it a lot, but I have a little asterisk or caveat by it. So I think, like you said, for a differential diagnosis, you can have somebody put mouth tape on, or if you don't want tape, you can have them hold a tongue depressor between their lips, or you
Right.
can have them hold water in their mouth. And
Yes.
the idea is you check to see, can they get to 1 minute, can they get to 2 minutes, and can they make it to 3 minutes? And if you can make it to 3 minutes with your lips taped or mouth closed, breathing through your nose, according to Patrick McEwen and a lot of other people, he says this all the time, if you can breathe through your nose for 1 minute, you can breathe through your nose for life.
True.
So you just aren't used to it.
Exactly.
And it doesn't
Learn
mean
it.
you don't need nasal surgery or you don't need other things, but you can at least start the process of practicing using your nose
Right.
and building up CO2 tolerance, which is, again, another topic that when we mouth breathe, we don't have enough CO2 in our bodies,
Right.
which is really helpful for the respiratory process and
You don't
oxygen
overbreathe. You don't
absorption.
overbreathe CO2 when you
Yeah,
nose breathe all the
exactly.
time. Yeah.
So I use mouth taping in my exam like that to see if people, if they can't make it for a minute, before I work with them, they need to go see an ENT.
Mm-hmm.
Now, as part of therapy, I recommend mouth tape as a passive exercise. So I start with 5 minutes, and people work up to 10 minutes, 20 minutes, until eventually during the daytime they're taping their lips for an hour. And they might also be practicing their tongue posture at the same time.
Right.
Once people can consistently do that, an hour during the day while they're awake, then I'll say, for some patients, and it's going to depend on the age, then I like to start doing it at night, because if you can keep tape on your lips and breathe fully through your nose all night, it can be life-changing, literally. And this is one of the biggest, most helpful tools that I think a lot of people with sleep disordered breathing experience, is once they start doing the mouth taping at night, now they realize they're sleeping better, they wake up feeling more refreshed. It's translating over to better daytime nasal breathing,
Right.
because you've got a big chunk of time, 6 to 9 hours that you're doing that, and it's really good for your body. And so I don't recommend mouth taping right off the bat, because I like to make sure people are efficient with the daytime nasal breathing, and that they, if they have to have ENT clearance, then I don't want them to just put tape on their mouth right away. I think that's important
Right.
to know. But
Yeah.
I do love mouth tape. I think it's a great tool.
I use it in my practice for many things. There are a lot of borderline patients
Mm-hmm.
that it's sometimes difficult to tell what putting tape on at night does. I mean, if they wake up with headaches, it's hypoxia. That probably is a deviated septum or a narrowing of the, compromise of the nasal patency. But in general, it's I mean, I tell patients, if you could control the pH of your blood, and the pH of your blood really is responsible for so much, overall health, immune response, overall well-being, then would you be willing to do it? And they're like, yes. Well, that's my way into telling them about myofunctional therapy.
Yeah.
Being able to breathe through your nose is so important for so many reasons. I mean, for example, the lung microbiome, it prefers that moisture-rich, humidified, warmed air. I mean, we could go on and on about how nose breathing is so important, but let's stick to myofunctional therapy. Nose breathing is a big deal when it comes to sleep apnea. It tells me a lot about how they've developed. It's just one little puzzle piece in the whole sleep apnea kind of puzzle, and it really helps me as a provider. So I'm a little bit more abrupt than you. I just tell them, this is what you're going to do. I give them a demo. You're going to go home tonight. You're going to tape. And I do that with kids.
You're a doctor, so you can do that. Maybe. I'm like, I have to be a little more careful.
And most of the time people come back and they go, well, something's different. That was really amazing. And again, these are people, so mouth taping works well with people that can breathe through their nose, but don't know how. So you force the issue. So that gets the conversation started. For people that cannot breathe through their nose, it's pretty obvious, but I use mouth taping as a way to keep the conversation going. So you can't mouth tape? What's wrong with you? Come on. I mean, you should be able to breathe your nose. Then we start talking about surgery. And then there's that in-between group where they can, but they're not, they may have to slow down their heart rate or their breathing rate to accomplish it. And that's information for me as well. So, but mouth breathing is a real. So how do we get to be mouth breathers? Let's talk about that. What perinatal, prenatal advice are you giving parents?
It's so hard because we don't always know the root cause, but what we're finding is that we've kind of had it in reverse. So we always thought that large tonsils and adenoids cause mouth breathing. What we're really learning is that often mouth breathing starts, maybe with a tongue tie, maybe with some cranial strains and some complex stuff that happens with breastfeeding during the birth process. There's so many things that can be.
That's why the tonsils enlarge.
Yes, and exactly. So the mouth breathing then leads to the large tonsils and adenoids, which makes mouth breathing more, more likely to happen. And so it's this feedback loop where the mouth breathing causes the inflammation makes mouth breathing more likely to happen. And so this continues, and a lot of it starts with stuff that happens when we're born and when we're babies. So I think tongue tie for sure can lead to mouth breathing. There's also kids that have allergies, food sensitivities from a very young age. They're struggling to breathe, and that inflammation then, can probably lead to the adenoid and tonsil issues too. I think one of the biggest things parents can look for is, do your kids have, it's kind of this triad of symptoms: tongue tie, adenoid issues, and ear infections, so ear tubes. Those three are often all together, and those are the kids that we see who are mouth breathing when they're 2, 3, 4, 5, and those are the kids that as they grow into adults, they have compromised facial and airway development, so now they have sleep apnea. So I kind of was talking about before we started, it's a really bold, big statement, but it's true. The kids we see with these myofunctional issues are the adults we see with sleep apnea. And that's a huge deal. That's a really big deal. So
we're still in the chicken or the egg kind of phase. I mean, we know what to look for. We know it's a problem, but what exactly causes what? And that's something that needs to be sorted out. And I think we're getting there slowly.
Yeah, for sure. I think the tongue tie issue is complicated because we are seeing a significant amount of tongue ties. And if you read, books like Jaws, or I know Dr. Kevin Boyd talks a lot about these epigenetic changes that are happening to our skulls, our jaws. Part of the soft tissue dysfunction that we see today is generational. It's been these epigenetic changes that have happened over the past 3, 4, 5, 6, 7 generations. So, if there's a parent who's slightly tongue-tied, and then they have a kid who's a little more tongue-tied, and then all these generations go by, just the same way that we're seeing changes in the jaws, we're also seeing changes in that soft tissue midline development. And there's a ton of other theories around like MTHFR gene mutations and methylation and all this stuff. That
which vitamin B12 you're taking in your diet.
Exactly, vitamin D. gut health. I mean,
Yeah.
all this stuff, so I don't know the answer, but I know that we're seeing different pieces. And, I don't know that there's one answer, to be honest. I think we're at this point where we're seeing a lot of these problems for a lot of reasons.
Right.
So,
Yeah. It's a very complicated field and area of research and work. So, but that's why we're here. So let's talk about tongue tie. Let me first say I've been I'm on record for recommending that a tongue tie specialist be there at the birth of your child. I don't
really,
know how
yeah,
that would work practically speaking, but I think it's important because hospitals now are looking for anterior tongue ties, and I mean for tongue ties in general. And the anterior tongue tie is very simple to see. It's like a small, your dog on a leash kind of thing, right?
Mhm.
It's constricting the movement of the dog, and the dog's not happy, right? And that,
Yeah.
of course, would affect breastfeeding, and we know where that goes. But what
Mhm.
about the posterior tongue tie? That gets missed a lot, and the reason I know this is because that was missed with my granddaughter, who's now 3 years old. Of course, it was fixed, but the first few days of breastfeeding for both mom and granddaughter, Quinn, it was very, very, very difficult.
Yeah,
And it can go beyond that: postpartum depression, nipple soreness,
for
mastitis of the
sure.
breast. I mean, it's an area that I don't know that much about, but I experienced, and it was because of this posterior tongue tie. They saw that there was an anterior tongue tie. They took care of that right away, which is
Yeah.
wonderful. So that posterior tongue tie, it was something that we found later. I stuck my finger in there, and it just didn't feel right, but I didn't know it was a posterior tongue tie, but certainly it wasn't what I thought was normal. So
Yeah.
what do you think of that recommendation? I mean, how do you get that person there? Are they there for the whole,
I
I mean,
think,
I would just call them in on an on-call basis, but to identify that posterior tongue tie at the right time, I think is
yeah.
so important for the rest of that person's life.
I think
So is
yeah, if
it,
any mom can have lactation support, almost like plan for it. I mean,
Mhm,
if okay, this is my due date, this is, what we're looking at, having a lactation specialist who understands a posterior tongue tie, who's
mhm,
understanding the function, because it can go both ways. There can be babies with a posterior tongue tie who they feed fine, they're gaining weight, and even if it's an obvious one to someone like me, most people say, "Oh, it's fine. Don't worry about it," because they're gaining weight. Well, right at that 3 month mark, when the mom's hormones start to change and the natural expression of breast milk starts to slow down,
mhm,
this is where that posterior tongue tie can start to really show up
right,
and be a challenge. And so things might be fine when there's a lot of milk and it's easy, and the baby, they don't have to function very well. They don't have
right,
to have good tongue mobility, and even lip flange from lip ties. It's a really big
yes,
deal. Once they get to the 3 month mark, this is where some of the struggle can set in. So if it would be at all possible, like you're saying, to have somebody there from the birth,
right,
from like day 1, day 2, day 3, to be able to look for that, so that way you can deal with some of the functional side before it becomes a
right,
problem,
right.
would be so ideal. But I think people have to be aware, and this isn't like to say anything bad about hospitals or like mainstream, medicine. They're not looking for it. So
Yeah,
you have to find, you might not be able to trust that the doctor looking to inspect for the tongue tie even knows what to look for, or that the lactation consultant at the hospital knows what to look for. So it's a lot of work, to be honest. You have to seek out the people,
right.
and you have to really be an advocate for yourself, because unfortunately, and again, I'm not trying to say anything bad, it's just the way our system is. We just don't have this knowledge. It's not mainstream. You've got to find the people yourself, and not everyone has access, and
Right.
that's a whole different discussion. But
Right. That is.
yeah.
Yeah. I mean, tongue tie is a big issue. So let's talk about your Skype and Zoom consultations, but in
Mhm.
conjunction with the tongue tie. So um, I think it's maybe. I mean, how would you? I think there are a lot of people out there thinking, I know I don't have a tongue tie because I don't see it, but what if I have a posterior tongue tie? How would
Yes.
you, on a Zoom call, know that that person has a posterior tongue tie? I mean, there are
Yeah.
indirect ways
So,
of knowing.
oh yeah. So there's a lot. Okay. This will take me. I'm gonna get on like my little
Oh,
educational
no,
kick
let's do it.
here.
Yep.
So I talk about the 5 pillars of tongue tie identification, and there's not just one thing that we're looking for. So there's visual appearance. We're going to look for like a deep groove down the center of the tongue, a heart-shaped tip. Does the frenum look like it has kind of this Eiffel Tower flared attachment?
Right. Yeah.
And there's some visual things you can pick up on. Function is another thing. If you're an adult and you feel like you cannot use the tip of your tongue to touch the backside of all your last molars, functionally, that's not good for cleaning your teeth. Like on the very most basic level, cleaning food out from the back of your teeth.
Right.
That's a functional issue. Functional to me, looking at function, can your tongue rest in your palate? That's function. And you have to be able to do it at night, not just during the day.
A lot of people with a posterior tongue tie are able to stick their tongue way out.
Way out.
And that's not indicative of anything. So
Exactly.
While you were talking, I tapped the back of my second molars.
You should be able to. And I think third molars, I wouldn't think that everyone can reach back. I don't think that's necessarily, I mean, who knows? But I think back of second molars, you should be able to touch, and you should be able to keep your tongue in your palate. The back of the tongue, that's the posterior part, is can the back of the tongue raise? So there's visual appearance, function, there's compensations. At what expense are you functioning? So are you using all the muscles in your neck and your shoulders? And so people with tongue ties often have a lot of occipital pain. They have a lot of neck and shoulder issues because they're using all these accessory muscles to compensate for the fact that their tongue can't move well. So visual appearance, function, compensation, measurements. So if I was there with you in person, I can measure the frenum, I can measure your maximum opening, I can measure, all of these things with your tongue. And so that gives us some insight. And then the last thing is symptoms. So sometimes people don't look like they have a tongue tie, but they have all the symptoms. They've got sleep disorder breathing, they've got TMD issues, they've got, all the things that to me point to the fact that you probably have some degree of tongue restriction. And so we have to look at it from many aspects. And I think that's a long way of answering your question, but if I'm looking at someone, there's a lot going on in my mind that
I knew most of that, but I wanted you to be able to say that because it's important. I think now people know they can check that themselves, or they can just, you're just a phone call away. A myofunctional therapist can quickly help people with this, and that can explain a lot. How is, you were mentioning, TMJ and those kind of symptoms. How does bruxism tie into, let's start with the tongue tie, but in the myofunctional world in general as well. But how does, a lot of people ask about bruxism, and you were also talking about neck issues, levator muscles, traps, and all that. All of that is tied in with sleep posture, not being able to breathe properly, getting that airway open by pulling your head off the pillow or leaning forward. And then bruxism is part of that too. How does that, how would you tile that in?
There's I can narrow it down to 3 ways, basically. You touched on it. When you can't breathe, you're more likely to put your head more forward. And so a lot of people it starts with the tongue tie, which leads to kind of smaller oral space development, which leads to smaller airway development. So people will posture forward, and that creates a lot of just neck strain. Also, I think during the nighttime, what we see a lot in patients who can't breathe well and who are maybe forward head posture during the day, their body is moving the mandible forward to potentially try to open up the airway. So that can lead to a lot of the grinding. There's also a lot that now we're learning about just your body existing this sympathetic tone. You're existing in this fight or flight stress state while you sleep. So you can really be clenching your teeth quite a bit. The tongue tie component, there's an overlap with the airway stuff with tongue tie, but it's also, it's really fascinating if you look up something called the deep front line by Dr. Thomas Myers. He has a whole book called Anatomy Trains, and he talks about the fascia system. And so when we're tongue tied, we tend to have a really tight fascia system down the whole front of our body, our whole deep front line. And then again, it's tight fascia, it's tight muscles, but it's also the muscles overcompensating for the tongue not being able to be so mobile. So the head, neck issues, clenching, grinding issues. It's all in response to the airway side of things, and then the muscle dysfunction
Right.
that tends to be there when you're tongue-tied.
Right. And the fascia. I mean, some people are
Yeah.
calling that as an organ system. I mean, it's that important.
For sure.
And, you know, we could talk all day about myofascial release. They've been on that for a while, but I mean, I agree with you. I know that I had a lot of neck issues. There would be a few days every year where I would wake up and I couldn't turn and I couldn't do this, which means I couldn't do my job. So I would take the day off. And when I fixed my mild sleep apnea, 12 interruptions per hour, and I got it down to 0, my neck pain went away because it's all related to posture. I thought it was an occupational hazard. I did a lot of Pilates, which helped. But again, that was not dealing with the root cause. The root cause was my breathing at night, lifting my head off the pillow. And that, as you said, that sympathetic tone. I mean, if you are struggling to breathe at night, trust me, you are one nervous person. You are fight or flight, and you are not relaxing. Your body is not able to repair itself at night if you are in a sympathetic tone. Cortisol, adrenaline, all those things are flowing, and your body is not paying attention to what it's supposed to be doing at night.
Yeah, I've even heard people talk about, joint pain and, all of these things, because if you're not getting to those deep levels of sleep, which I know this is your area of expertise, you're not getting into that regenerative state. You have a lot higher inflammatory levels. And what I'm really interested in is something that is just starting to get talked about, and that is the autoimmune connection to sleep disordered breathing. I'm just hearing people starting to get into that. And I think that has to do with inflammation and our body's not repairing and regenerating at night. So and plus high stress, sympathetic state all the time. So I don't know if you've heard much about that, but I find it really
interesting. No, I've been reading about that. It's fascinating. Also, connection between sleep and the gut microbiome.
Yes.
There's the oral microbiome and the influence on the gut microbiome. I mean, it's pretty clear. And I know by the time I'm not on this planet, we will not have it all figured out. It is pretty clear that the body is incredibly complex and beautiful. And, it, despite a lot of epigenetic factors that we've introduced into our environment, it does pretty well. Let's talk about epigenetics. I mean, that's kind of a interesting topic because I think a lot of us think, oh, that's just my facial type. I look like my mom or dad, and it's all genetic. And, I refuse to think that way because it's really all about genes that we have, but whether we trigger them or not, or whether we activate them. And unfortunately, there are a lot of things in our environment that do just that. So how does the myofunctional world look at that? Epigenetic factors like poor air quality, mouth breathing, not able to breastfeed. There are a host of others.
Well, I referenced 2 books, or a book earlier, Jaws by Dr. Sandra Kahn and Dr. Peter Ehrlich. And they talk a lot about this. And then also Dr. Kevin Boyd talks about this as well. And I mentioned him before. A lot of this stuff started during the Industrial Revolution. So we can look at like pre-industrial people and how their jaw structures are and their teeth and their breathing, and then post-industrial people. And that wasn't, when was the Industrial Revolution? I don't even know the years, but it's like
1800s.
1900s. So there's been a lot of changes since then in a very short period of time. And we can see that the more industrialized humans became, through like the 1700s, 1800s, those type of, back in that era, when people got more processed food, once they started moving to bigger cities where there is a lot more air pollution, they can't breathe as well. Now those changes are taking place. The one thing that Dr. Kevin Boyd mentions that I think isn't talked about as much is during the Industrial Revolution, that's when women started going from like cottage industry, like working from home and being able to breastfeed babies, to working in factories. And so that's where changes in breastfeeding started, pollution, diet. And so a lot of these things, like I said, it's a combination of a lot of changes that, doctors like Weston Price would go and they would go to these remote communities where they didn't have anything modern or industrialized, and see that the people had wide palates, really like no tooth decay. They were all nasal breathers. They didn't have all these modern, modern problems. And so I think, it's
thank goodness we have that as a reference point, because we may not have noticed. We may have thought it was a normal evolutionary change, which it isn't. And
I
in
know,
the late,
it's so good.
yeah, in the late 1800s, when that industrial revolution started, a lot of things changed. Our diet changed. We
Yeah.
lost a lot of our ingredients, our topsoil. Mark
Mhm.
Hyman speaks of that so wonderfully in Food Fix. Talk about a root cause. But it's not only just, lacking certain minerals and
Yeah.
substances like K2 and
Mhm.
other vitamins, but it's also the consistency of our food. I mean, baby
Mhm.
food, pureed food is not, and I know everyone's afraid of choking and
Yeah.
aspirating food and all that, but our little granddaughter is chewing on lots of crunchy and delicious
Good.
chewy things, whole foods, right? It's not
Yeah.
just the nutrients, it's the texture, it's how much work it takes to break it down, which is key
Yeah.
in facial development.
Which is so interesting, because I listened to a lecture with Paul Ehrlich. I don't know why I can't say his name.
Ehrlich Paul, yeah, and
Um,
Sandra.
he was talking about how even our food, what we have as a peach today
Yes.
is juicy and like really soft and
Yep. Yep.
super sweet compared to a peach 100 years ago, which probably would have been a little more tough.
Yep.
And so we've even modified our food, not like genetic modification, just breeding, it's
Texture,
been, yeah,
size, color, texture, all of that.
exactly.
Tomatoes have changed. There
So
are
much.
discussions
And so
about
when you,
lectin and quantity, and I mean, we have genetically engineered ourselves into a small airway and a lot of suffering.
I know, it's
Great job.
crazy.
Yeah.
And it's really amazing when you think, like I said, there's not just one thing. There's such like so much stuff coming together that has led us to where we are today. And
Yeah. Yeah.
I look at every other field in the rest of medicine, and healthcare, and I think, if this is what I know about my field, like this must apply to every
Right.
other
Right.
industry and every other part of healthcare. There must be these same conversations happening on different subjects throughout the whole body in different
Right.
like small groups, like me and you talking about this in the dental field.
Right.
There's got to be other people talking about this in other areas too.
So it's overwhelming to me,
Mhm.
to you, and we're on the forefront. We know it. We read about it. We're total nerds when it comes to this.
Totally.
We live and breathe it literally. What I mean, and it's overwhelming. It's sometimes depressing, right? But
Yeah.
what would you say to a person that's listening to this, whether it's a dentist or a patient, layperson? I mean, they're probably a little overwhelmed right now in what you know and what you can do, what a myofunctional therapist can do. What one or two sentences would you say to make them more hopeful that there's hope and that change is possible, improvements are possible?
Yeah. Awareness is the key. So if you're aware of these things, now you can take the steps to change them and you can help yourself. But if you're not aware, then that's when we can feel like there's no hope. Once we become aware of the fact that there is an issue, now we can change it. So I think if you can find dentists who are aware of this and work with those dentists, that will help grow the awareness of this in general, because um, once patients start going to their dentist or seeking out the dentists who have this understanding, kind of this more comprehensive, overarching approach to root causes and stuff,
Right.
I think it's all about awareness. So
Yeah.
if the patient's aware, the doctor's aware,
Right.
now the general public can become more aware, and then we can start taking up, little bits at a time. We can start changing it.
Yeah, I agree. I think awareness is the first step.
Mhm.
And I would add to that, I would say, because I see a lot of frustrated patients, and they're so overwhelmed that they're not willing to act. And to them, I say, whether it's online or in person, I would say to them, you have the awareness. Obviously, we wouldn't be having this discussion. That's the internet, the democratization of healthcare, which is wonderful. But it has a
Mhm.
downside too, is that there's so much information out there. Not all of it's correct. What do you do with all that information? And I tell them, you now know that you need to do something. You've been enlightened, and the important thing is you know that the person, the healthcare provider that you're seeing, if they don't know, then you know to switch. In
Yeah.
general, if you're feeling overwhelmed but you want to do something about it, find a practitioner that can help you. Put your trust in that person. At least you've picked a better person based on your knowledge and your
Yeah.
frustration and being overwhelmed on all that knowledge. So again, being informed is a good thing. Just be willing to hand it over to someone. Just find the right person. So
Yeah. And I think as far as my stuff goes, there's so much you can do on your own. I mean, you can practice nasal breathing and tongue posture on your own. And if you need help from a professional, then you can always seek someone out. But just getting you or your kids to start nasal breathing is the first step. So that is huge. And like you said, the mouth tape. I mean, there's so much that you can. I think if people feel empowered to do stuff on their own too, that's also really helpful. It helps with that overwhelming feeling.
Right. Yeah. Well, we've been talking, I think, for more than an hour, so we should definitely wrap things up. I don't want to go on too long, although we could easily, and we'll do this again. I just want to say that I wouldn't be the dentist that I am now if it wasn't for someone like you, Sarah, and my affiliation with you. And I think I'm saying that because I think dentists need to have a mentor like you, because we didn't get it. And we still don't get it. So how let's start with that first, because I want to also connect you with patients. How would patients find you? How should a myofunctional therapist and a dentist work together? How does that work? And how would they find the right one? How would a dentist, I mean, there's some dentists out there going, oh my God, I got to find someone. How would they do that? And what should they look for?
Yeah, I mean, it's such a big question. So I have a program that I'm super proud of. It's called Myo Mentor, and I basically am a mentor for hygienists who want to get training in this. So I have a huge database of hygienists who have gone through my training program. And there's also been several dentists who've gone through that as well. So if somebody wants to reach out with me and get paired with one of my students, I would be happy to help with that. But there's also, we have a lot of training organizations. There's IAOM, AOMT, a handful of others that are out there. If you look up their websites, you can find myofunctional therapists. And then my big passion, which I was telling you before, is connecting people. So now that I have such a amazing community of like-minded providers, I love finding the people and matching them together. So I love connecting the dentist with the hygienist, and then helping them start study groups, start building the awareness in their communities. There's so many patients who need this. I don't need to see them all. I want all of these communities to start building and developing their own awareness and knowledge in their area. And then that can help all those patients there. So it's kind of that ripple out effect.
So you're a myofunctional matchmaker, essentially.
Right? I am. Yeah. I actually have a program called the Matchmaker Program.
Oh, there we go. Okay. How about patients? How should they go about? Should they talk to their dentist? What if their dentist says, I don't know of anyone? I mean, can they reach out to you? Can they?
Yeah, please reach out to me, because like I said, I can pair you with the dentist. I can pair you with the hygienist. I have an awesome team of myofunctional therapists. I should give them all a shout out. Megan Vanoy, Tamara Lindley, Kimi Nishimoto, Nanette Tesauris, and a handful of others. And they all will see patients. If you reach out to me, you will probably end up working with one of those therapists. And they all have gone through my training. They all are aware of this stuff. They're all super passionate and enthusiastic, just like me. And they are out there in their individual communities also trying to spread this awareness and knowledge.
And, if you're listening now as a patient, and I just want to tell you, I hope after this hour you've gotten the idea, but, listening to all those names, one of those names could be one of your most important healthcare providers for your children, for yourself. It's that important. So so your website is wonderful, I have to say, Faceology, right?
Yeah, Faceology.
And I would, if you're interested in any of this, I would go to Sarah's website. It's fantastic. There's a wealth of knowledge, a lot of interviews, a lot of connections, and also now you're working with one of the leading tongue tie experts in the world at UCLA, Dr. Zaghi, and the Breathe Institute, right? Is that right? Breathe Institute, yes.
The Breathe Institute.
And so that's exciting, and I think it's wonderful what you've been doing, and I think it's an extremely valuable healthcare process that maybe is undervalued, but less so,
totally.
And a lot because of what you've done. So I want to thank you for that, and I just want to say that we will definitely be talking again.
Yes, let's do this again. I think it's really great, and thank you.
Because there'll be lots of questions, and again, anything you know of that's new in the myofunctional world, please let me know right away, because that information needs to get out. So
Awesome.
again, thanks, Sarah, for spending a lot of your valuable time. and enjoy your new affiliation with the Breathe Institute, and hopefully I'll be seeing you soon. Thanks again.
Thank you.
Take care and stay safe.
You too.
Okay.